Okay. Well, first of all, thank you very much for the kind invitation to this International Forum on Critical Care Blood Purification. I think it is very timely and very important due to the very recent developments we had. And I must say that after the Vicenza course last June, we have had an ADCI meeting on the consensus conference on sepsis-associated AKI and relevant therapies. So this is very, very important. I will just begin my talk saying that the origin of blood purification in critical care medicine goes very much behind in World War II, when Bywaters described cases of acute tubular necrosis due to victims of crash syndrome. And in Korea, the mortality of acute kidney injury decreased significantly because for the first time to treat military casualties, there was the artificial kidney. And this is the very first application of an acute dialysis at the field of a battle. And this is a courtesy of Professor Paul Techin that sent me these rotating drum pictures. Of course, immediately after, the idea in Vietnam to medevac patients rapidly and infuse large quantity of fluids made possible to develop a strategy to prevent acute kidney injury. But subsequently, if you look at the incidence of acute kidney injury in our department, in the 5 years, 74 to 79, we treated 48 patients, and only 15% was in the ICU. Subsequently, 95 to 2000, we treated 525 patients and only 8% in the renal ward, all the rest, 92% in the ICU. Mortality was more or less the same, but of course, the severity of illness was increased. And in fact, we published with Rinaldo Bellomo this concept, critical care nephrology, the time has come. And in this editorial, we made clear that renal medicine and ICU should have a very high interaction due to the possibility that patients may require combined therapies. And in fact, this has become a kind of a discipline, and you may be aware of the publications concerning critical care nephrology that we developed over these last years. Everything started with the CAVH, continuous arteriovenous hemofiltration. Here you see the circuit without blood pump. And here you see how blood lines were short in order to guarantee enough blood flow in the extracorporeal circuit. Subsequently, we developed continuous arteriovenous hemodiafiltration, circulating dialysate countercurrent to blood in the dialyzer. And then subsequently, catheters were utilized for veno-venous hemofiltration, utilizing machines or pieces of machine from the chronic dialysis. This allowed, however, to develop the different type of techniques, as you can see here, thanks to the presence of blood pump and ultrafiltration control. The first step forward was when Prisma entered the market with a preset cartridge that was self-loading in the machine. And subsequently, there was an evolution of this machine going to the final type of machines of the fourth generation for CRT. The same is true for different companies. For example, this was a series of prototypes we developed originally that started to develop the final Diapact machine. And today This is the prototype of the Omni machine that was entering the market very, very recently. So again, a series of development that led to last generation of dialysis machine. And as you can see here, 40 years of development from CAVH to CVVHD, and then machines, and then developments of multiple organ support therapies. And finally, more recently, we have also the possibility to add the special machines like the F20 from Jafron with the hemoperfusion capabilities, or hemoperfusion plus hemodialysis, or DPMAS, which is a double plasma filtration molecular absorption system for liver support. Also, in Vicenza, we developed the technology for mini filters to treat neonates, and this is the Carpe Diem machine that was developed in our center a few years ago. Again, in pediatric, we also saw 40 years of evolution towards new devices, and finally to the most recent neonatal CVVHD machine. Now, the treatment was always a question when to initiate, and there is a consensus today that when demand and capacity are actually mismatched, there is more demand than capacity of the kidney. This gap may represent the important aspect to start the therapy. And in fact, we have therapies today that can be prescribed, and data can be collected in machines, in medical records, or even in the cloud, with the possibility to acquire information about filter life, treatment downtime, delivered dose, fluid removal, alarms, etc. And therefore, we know much better what are the timing of initiation, how the fluid overload is managed, and how much initiation was early or late, and the frequency of renal replacement therapy after CRT. One of the points about dose was always the fact that increasing the dose provides increasing survival until a point in which basically the increase of dose becomes useless, and mortality is independent from the dose. But of course, there is a variation depending on practice. Our scope with our machine and the evolution of technology is to move from a large deviation from the physiological target line to a less severe degree of amphysiology, bringing the patient close to physiology. And technology can help because we can somehow describe the pathways that lead to the optimization of achievement of physiological targets. And when there is a change in trend that tends to deviate from the adequate prescription, we can modify prescription. This is the concept of assisted dynamic prescription that can apply to the dose or to the fluid overload, depending on the trend that you can observe in patients. And here is how technology has evolved over the years. Today we have scores and biomarkers, and information technology can help with electronic medical records. Clinical diagnosis is also done through automatic e-alert system, and indications may be considered relative, absolute, or also non-renal for extracorporeal blood purification. Then, once you decide to start prescription, you identify your targets and you prescribe dose, volume, homeostasis, organ support. Prescription is made according to different techniques: machine, filters, fluids, settings, anticoagulation, and delivery is observed and monitored. And if data are achieved, you can somehow monitor and decide whether or not to modify prescription. One of the systems that is available today is the so-called automatic fire feedback that signals from laboratory, patient, and machine can be conveyed in a computer and can have a biofeedback that can be nurse authorized or automatic from the machine. And this is an example of some machines that adjust prescription according to actual delivery in order to achieve final results. One of the evolutions in the area of blood purification has been the multiple organ support therapy in critical illness and sepsis, what we call the MOST, thanks to different technologies. And since we know that different organs are involved, we can consider that we can provide support to different organs just by modifying the characteristic of the extracorporeal circuit from ECMO to dialysis to plasma filtration exchange to hemoperfusion. And at this point, we call this extracorporeal organ support therapy, which typically is of great interest in sepsis. And this was a paper we published in JAMA showing that today we can support lung with ECMO or extracorporeal CO2 removal, heart with circulatory support and ultrafiltration, the kidney with dialysis, the liver with DP mass and albumin dialysis. We need to pay close attention to the interaction of crosstalk between artificial organs. And in fact, these different organ support systems must interact one to another in order to make sure that there are no detrimental effects. And we need integration of techniques and hardware in order to have a fully integrated hardware. In case of sepsis, we are well aware about the cascade that begins from infection to immunodysregulation and organ damage. And these effectors, humoral and cellular, are well known as DAMPs and PAMPs. And this can be somehow removed from the circulation, especially pathogen-associated molecular patterns with specific hemoperfusion, specific cartridges, or you can remove cytokines and damage-associated molecular patterns with other type of sorbents, as in the case of Jafron cartridges for cytokine absorption. We know that removal of endotoxin can be beneficial, and this can be achieved, as I mentioned before, through a specific system. But we also know that the DAMPs may require removal due to the immunodysregulation. And host-derived molecules mostly include the shock proteins, cytokines, chemokines, and other type of peptides and molecules and biomarkers. Our approach is basically consisting in the fact that there are too many molecules that are activated into the circulation, and to block just one molecule will not be probably sufficient to achieve some immunomodulation. And therefore, as you can see, whether you have pro and anti-inflammatory mediators activated sequentially or even simultaneously, cutting the peaks of these molecules may somehow restore, at least in part, some immunohomeostasis. And as you can see here, blood purification therapies find their rationale in this case, originally using high volume hemofiltration, subsequently utilizing high cutoff membrane, and finally today proposing hemoperfusion as the right solution. So again, in the early phase, endotoxin removal by hemoperfusion with polymyxin B cartridge, or subsequently removing cytokines and chemokines with different type of sorbents, and finally providing organ support. We also proposed the use of cytokine removal in COVID-19 patients where they could prevent the effect of cytokine release syndrome and organ damage. And the concept, again, is that from viral infection, pneumonia, and activation of all the mechanisms leading to endothelial dysfunction, you can observe early overwhelming inflammation due to innate immunity or late deaths due to intractable inflammation. But you can also observe late deaths due to persistent immunosuppression due to the activation of the adaptive immunity. Therefore, modifying the circulating level of these substances may induce a non-specific cytokine blockade with endothelial protection and possible organ protection. And this can be done with the classic hemoperfusion circuit using a sorbent or using sorbent in combination with the dialyzer in hemodialysis or CRRT, depending on where the patient is treated. There are several conditions with uncontrolled cytokine release that can be considered important indication for removal, like sepsis, septic shock, severe viral infection, hemophagocytosis, lymphocyte histiocytosis, and CAR-T therapy. And acute pancreatitis can also be an important indication. Recently, ADKI 25 on COVID-19 has proposed the use of different type of membranes for different targets, including the possibility to utilize hemoperfusion for specific molecules that cannot be removed by dialysis. These molecules often are in the so-called large middle molecular weight spectrum from 25 to 50 kilodalton. And these represent molecules that can hardly be removed by classic membranes because of the typical cutoff curves, even of the most recent medium cutoff membranes. For this reason, surface modification has been proposed on the possibility of membranes utilizing some type of absorption on the surface, but the mechanism of absorption is certainly the new frontier in terms of blood purification in critically ill patients, because there is a rationale overcoming limitation of dialysis membrane, potential selectivity of the process of removal, and possibility of placing the sorbent in contact with blood due to high biocompatibility of the new sorbent materials. And in fact, there are several different options that are available. This is the spectrum of cartridges proposed by Jaffron, and you see in several different conditions that you can have beads with characteristics that lead to removal of different molecules. We studied the biocompatibility of this sorbent both in static and dynamic tests. No changes in viability of cells incubated with the sorbent, no changes in apoptosis compared to static and dynamic methods, and finally, no changes in necrosis compared to the system. So this type of resin has been utilized in combination with veno-venous hemofiltration for patients with multiple organ dysfunction syndrome, in some cases demonstrating significant improvement in 28-day survival, although the studies that have been done so far, must say, are of limited number of patients. We, in our own patients, have observed also a biological effect, not only removal of interleukin-6 and reduction in requirement of noradrenaline to achieve an adequate mean arterial pressure, but also an improvement in monocyte function as testified by phagocytosis and TNF production. And an improvement in antigen presentation capacity represented by the number of monocytes expressing HLA-DR on the surface and the quantity of expression of these molecules. So these type of cartridges have now been proposed for different indications, including sepsis, burns, trauma, cardiac surgery, acute respiratory distress syndrome, and pancreatitis, and sometimes even in combination with ECMO and cardiopulmonary bypass. There is a rationale for a precision extracorporeal blood purification therapy. Large randomized trials provide some evidence for clinical guidelines, but controversy remains and the practice remains variable. New trials gave no definitive conclusions because of heterogeneous results, underscoring a fundamental limitation of the randomized controlled trial policy. A single best solution may not exist for all or most patients. One size fits all will not answer complex problems, and there is no best dose of insulin to treat diabetes and no best antibiotic. So there is no best treatment to treat extracorporeal therapies in this patient. Treatment must be tailored to specific patient, specific condition, and the search for one dose, modality, and time for initiation that is best for all patients will never be fruitful. Now, as I mentioned before, since we know that we have a heart, lungs, and kidney interaction, the so-called organ crosstalk at multiple levels, general circulation, local circulation, tissue, and cellular level, we need to consider the importance that the different pathological conditions have on the kidney, so-called associating AKI to previous abnormalities. But we also need to learn how much mechanical ventilation, ECMO, or extracorporeal liver support may affect kidney function and cause possible kidney dysfunction. And finally, we must know how much ECMO, ECHO, or plasmapheresis interact with our renal replacement therapy in a new type of interaction called artificial organ crosstalk. So we move from native to artificial organ crosstalk. What will be the future? Patient's identification will allow to define timing, dose, and duration. Techniques of optimization will require adequate prescription and anticoagulation. And there will be more and more extracorporeal organ support technology development, including sorbents and sorbent techniques, integrated equipment for an easy management, and patient care and precision extracorporeal blood purification. Among the new devices, fluid balance control may be important, new membrane possibly, new sorbent devices, wearable device, and population-specific therapies. The recommendation published by ADKI say precision medicine is suggested in the evaluation to start or stop any type of extracorporeal therapy. Timing can be variable depending on capacity and demand, and criteria for stopping have not defined yet. More is better in terms of dose until a certain point where the curve reaches a plateau and dynamic prescription is recommended. Different modalities are available for CRRT and chemoperfusion. New technological advances should help clinicians to optimize prescription, delivery, and result evaluation. And these are the recommendations most recently that we collected for COVID-associated AKI and sepsis-associated AKI, where the group convened on the fact that the term extracorporeal blood purification includes all techniques from dialysis to hemoperfusion. There is a biological and clinical rationale for application of extracorporeal blood purification therapies, both in COVID and sepsis-associated AKI. Initial studies support this application, but more evidence is required for a general routine utilization. No recommendation can be made for all patients, but specific patients may benefit from extracorporeal blood purification therapies. In AKI, where CRRT is indicated, Hemoperfusion may represent an important and effective addition. More research is required to define patient selection, target molecules, dose, timing, and duration. But remember, 30 years ago, we were in the same situation with CRRT, and we need to establish now a research agenda for hemoperfusion.